Hello nurses, welcome back to our channel. Today we are going to understand diabetes mellitus in a very simple and easy way. This topic is very important for your exams and also for your clinical practice. So grab your notebook and let's start. First, where does the problem start? The problem starts in our pancreas gland. The pancreas is located behind the stomach in an area called the retroperitoneal area, pronounced as retroperitoneal. The pancreas has two main functions. First is exocrine function. It produces digestive enzymes to help with digestion. Second is endocrine function. It produces hormones through special cells called islets of Langerhans. Inside these islets, we have three main types of cells. Beta cells, 70%. They produce insulin. The main function of insulin is to lower blood glucose levels. Alpha cells, 20%. 20%. They produce glucagon. The main function of glucagon is to raise blood glucose levels. Delta cells, 5%. They produce somatostatin. This hormone controls both insulin and glucagon. So in a normal body, insulin and glucagon work together to keep blood sugar balanced. Now, what is diabetes mellitus? Definition: it is a metabolic disorder caused by insulin deficiency or impaired action of insulin. There are two main types. Type 1 diabetes mellitus. This is an autoimmune disease. The body's immune system destroys the beta cells, so there is no insulin production at all. It is commonly seen in children and young adults. Patients with type 1 will always need insulin injections. Type 2 diabetes mellitus. This is due to insulin resistance. That means insulin is present in the body, but the body cells cannot use it properly. It is most commonly seen in adults, especially those who are overweight. Type 2 can be managed with diet, exercise, and oral medications. Manifestations: remember the 3 Ps. Polyuria, frequent urination. Polydipsia, excessive thirst. Polyphagia, increased hunger. Other symptoms include fatigue, blurred vision, and slow wound healing. How do we diagnose diabetes according to ADA standards? Test number 1: fasting blood sugar. FBS. The patient must fast for 8 hours. Normal is less than 100 milligrams per del. Diabetes is diagnosed if it is greater than or equal to 126 milligrams per dl. Test number 2: random blood sugar. RBS. This can be done at any time. If it is greater than or equal to 200 milligrams per del with symptoms, it indicates diabetes. Test number 3: HbA1c. This test shows the average blood sugar for the past 3 months. Normal is less than 5.7%. Diabetes is greater than or equal to 6.5%. Test number 4: OGTT, oral glucose tolerance test. Give the patient 75 grams of glucose. Check blood sugar after 2 hours. Diabetes is greater than or equal to 200 milligrams per del. We also check urine for ketones when blood sugar is more than 250 milligrams per del or during illness. Let us talk about the right way to take insulin. The best site for insulin injection is the abdomen. Right technique: measure 4 fingers away from the umbilicus, which is the navel. Avoid the 2-inch area around the navel. Rotate the injection sites within the abdomen. Keep at least 1-inch distance from the previous site. Pinch the skin and inject at a 90-degree angle. Complications of insulin therapy. Lipodystrophy. 2 types. Lipohypertrophy causes a lump or swelling at the injection site. Lipoatrophy causes a depression or dark spot. To prevent this, always rotate sites. Dawn phenomenon. High blood sugar in the morning due to hormones. Soma-G phenomenon. Nighttime hypoglycemia, causing rebound high blood sugar in the morning. Technology like CSII insulin pump and CGM. Continuous glucose monitor helps in better monitoring. Acute complications develop suddenly and are life-threatening. There are 3 main types. A. Hypoglycemia. Blood sugar less than 70 milligrams per del. Causes too much insulin, missed meals or excess exercise. Mild symptoms: hunger, sweating, tremor, nervousness. Severe symptoms: confusion, seizure, unconsciousness. Treatment: follow the 15-15 rule. Give 15 grams of fast-acting carbohydrate like half a cup of juice. Recheck blood sugar after 15 minutes. If the patient is unconscious, give glucagon injection or D50 IV. B. DKA, diabetic ketoacidosis. This is mostly seen in type 1 diabetes due to severe insulin deficiency. Key features: hyperglycemia, dehydration, ketosis, acidosis. Assessment: fruity breath odor, Kussmaul breathing, which is deep and rapid, abdominal pain, and vomiting. Treatment priority: 5V fluids first, then insulin, then correct potassium levels. CHHS, hyperosmolar hyperglycemic state. This is mostly seen in type 2 diabetes. Key features: very high blood sugar, more than 800 mg per del, no ketosis, severe dehydration. Treatment priority: IV fluids first. Insulin is given later and slowly. Chronic complications develop slowly over many years due to high blood sugar. A. Diabetic retinopathy. This affects the eyes. The blood vessels of the retina get damaged. This can cause blurred vision or even sudden loss of vision. Nursing intervention: control blood sugar and blood pressure. Laser therapy or cataract surgery may be needed. B. Diabetic nephropathy. This affects the kidneys. The first sign is microalbuminuria in urine. Later, kidney function decreases. Symptoms: thirst, fatigue, anemia, frequent urinary tract infections. Intervention: control BP and sugar. Restrict protein in diet. In end stage, patient may need dialysis or kidney transplant. C. Diabetic neuropathy. This affects the nerves. It is the most common chronic complication. Types: sensory numbness in feet, autonomic gastroparesis, impotence, orthostatic hypotension. Mononeuropathy: damage to a single nerve. Because of nerve damage, patients cannot feel injuries. So foot care is very important. Inspect feet daily. Remember: no barefoot, no hot water, no tight socks. Cut nails straight. Use the mnemonic cut dry lotion. Cut straight, dry between toes, lotion, but not between toes. What if a diabetic patient needs surgery? Preoperative care: stop oral hypoglycemic drugs and metformin 24 to 48 hours before surgery. Adjust insulin dose. Monitor blood glucose closely. Postoperative care: give IV glucose with insulin until the patient can eat orally. Monitor the surgical wound closely because diabetic patients have a higher risk of infection. Monitoring is the key to managing diabetes. SMBG, self-monitoring of blood glucose. Wash hands, check the strip, and take the blood sample. Patient education and teamwork between doctor, nurse, and patient gives the best results. So nurses, to summarize, diabetes is all about an insulin problem. For your exams, please remember the 3PS, 15-15 rule, DKA versus HHS differences, and the 3 chronic complications.